Thank you for allowing me the opportunity to present this case. I changed the title, actually. It's a wire fracture in a complex bifurcation case. Okay. So we'll get going. I'm Dr. Ali from Mubarak Hospital in Kuwait. So I have a 60-year-old Pakistani lady. She has uncontrolled diabetes, hypertension, coronary artery disease. She had a remote PCI done in 2014 to the RCA. And she saw me in clinic, and she was having recurrent anginal symptoms. She had a diagnostic angio done prior to that, and it showed severe triple vessel CAD with a high syntax score. And she was referred to CABG in that center, but given her poor targets, she was declined CABG, and she was only placed on medical therapy. But her symptoms persisted, and that's why we pursued PCI for her. These are the investigations. She did an ECG, it showed normal sinus rhythm, some Q waves in V1 to V4. The labs, pretty much normal hemoglobin and renal function. She had an echo done, showed normal left ventricular function, diastolic dysfunction, and hypokinesia of the apex. So this is the diagnostic angiogram. You can see she has a severe proximal LAD and also ostial circ and distal left main. It's very calcified. Maybe, I don't know if you can see it in the projection very well. This is a different view, a cranial view here, and you see that actually the distal LAD is occluded. It's chronically occluded, and there's like a big septal coming up from the mid. Then the right side, there's a patent stent proximally, and then distally at the bifurcation of the PDA PLV, there's severe disease. This is IVUS run just to highlight the calcification that you see in the LAD. It's pretty much all calcified. Ostially, there's circumferential calcium, as you can see here. So just to cut to the chase, coronary intervention, this is what was going on. We wired all three vessels, LAD, D1, circ. We did multiple balloon inflations at several segments, and we also did shockwave lithotripsy in the calcified segment of the distal left main ostial LAD and also ostial left circ. And then we proceeded with stenting of the mid LAD segment. Eventually, the bifurcation was stented using the mini crush technique with 2 drug-eluting stents. And then we attempted to recross the side branch, which is the circ, and perform kissing balloon inflation. So this is the mini crush, 2 stents, one in the LAD left main and the other one in the circ. And then we had this initially, which it looks nice. Obviously, the wire in the circ is out because this is mini crush. And then while we were trying to recross the circ, this is just another view, a cranial view. Obviously, the distal LAD is extremely poorly diseased, and there was no targets for that. But then, when we were trying to recross the circumflex, you can see there's actually a knot, kind of looks like a knot around the stent in the left main. And as I was trying to pull, I noticed a lot of resistance, so I didn't pull very hard, but I tried to dislodge the wire with a microcatheter. It was, I think, a supercross, and even that would not dislodge the wire or retrieve the wire. So eventually what happened was that the wire got fractured, and you can see the wire was hanging out of the left main into the aorta. This is another projection of it, and you can see the wire is actually dangling in the aorta, hooked to the left main stent. So what we tried to do at this point, patient was actually stable, no chest pain, there was good flow. We tried to snare the wire, and we managed to successfully catch it with the snare. But then what happened, somehow she became unstable hemodynamically. There were STT wave changes. She arrested, and we had to perform CPR and put a balloon pump. This is before that, sorry. This is just a quick picture while the wire was hanging outside, and you can see TIMI3 flow and everything was fine. Sorry, here we were trying to dislodge the wire with a balloon. We were trying to inflate a balloon and pull, like we were just improvising at this point. And this is our snaring attempt, which we managed to do successfully at that point, but we couldn't pull the wire. So here you see the balloon pump and the aorta. This is when, after she arrested, we put CPR, we put a mechanical support with a balloon pump. At that point, she stabilized, and we were trying again to snare the wire. When we were snaring the wire, we catch it, we pull, but then we lose it. And you end up, you see, I don't know if you can, it's projecting very well, but you can see in the arch of aorta now, there's some fragments of wire hanging out, and we were trying to snare that. Then we thought we would use radial access. Maybe it will help us to catch the wire hanging in the aortic arch more easily. So again, at that point, we managed to successfully snare, but every time we pull, the wire would not come out. So eventually, we noticed that the radio-opaque part of the wire was gone in the left main, and we thought maybe with the snaring, we embolized the wire at that point. This is what our thought process was. This case took 7 hours. We were very determined to help this lady go through this. And you can see that the left main stent is actually deformed, heavily deformed. And what we ended up doing at this point, when we thought the wire was gone, we wired both vessels again, and we had to put a new stent in the left main. So this is the new stent in the left main, and this is the result at the end. So basically, at that point, I mean, the patient went to the CCU. She was on ventilator, and she was followed. So what we ended up having is we did an echo for her, and the echocardiographer noticed that there was fragments of wire still in the aorta. So what we thought was that we actually embolized or removed the wire. Actually, we did not remove the wire. All we did was unravel the coils of the fractured wire, and there was still fragments, remnants of the fragments in the aorta. So at that point, we decided to call cardiac surgery and see what they recommend. We talked to actually 2 different surgeons. They both said the same thing, to treat conservatively. And what we ended up doing was treat her medically. Obviously, there's no data to support any of what we're doing, but we decided to put her on Plavix and Xarelto for anticoagulation. The surgeons, what they said was that the wire is in a high flow system, so the likelihood of thrombosis is not that high. And doing an open heart surgery or doing like an incision of the aorta to retrieve the wire was risky. So I followed her at the outpatient clinic, follow-up. Until now, actually, she's doing very well. She has no cardiac symptoms, no history of stroke. She's at home pretty much very well. So what's the learning points of this complication? So whenever you have a fractured wire in the left main aorta, it's very difficult to snare it, and usually it results in unraveling of the coils, as demonstrated in this case. Surgical options can be considered, especially if the patient remains stable. And one of the solutions is conservative therapy, but this is controversial, and we don't have really any data regarding what is the best antithrombotic anticoagulant therapy, given the high flow environment, basically at the opening of the aortic valve. So what are other proposed solutions? I was just brainstorming at this point, like if you have this problem, what should you do from an interventional standpoint? One thing I thought about was whether rotablating would help, like it would just pulverize the wire and it will help maybe perhaps. Cutting balloon, I don't know if that's an option. It may cut the wire and dislodge it. Or maybe we can come up with some other snaring technique. So that's it. Thank you very much.